All right, guys, we're gonna go ahead and get started. So thank you so much for coming to the annual Community Health Speaker Series. This is our fourth one. If you haven't already signed up for our registration form, please do so just really quick. It's a couple questions. So I'll let you guys go ahead and scan that. All right. All right, so our agenda today, so right now we're going through our introduction. Next at 4:15, we're gonna have Dr. Kate York speak, and then we're gonna have some group discussions, and then Dr. Lee will be speaking, and then we'll do group discussions again. And then Dr. Irwin will speak again, and we'll have some more discussions. And then we're gonna have a brief presentation about SOL partnerships, and then have our closing. All right.
Yeah. So our Community Health Speaker Series is hosted by GlobeMed. We're a student org on UC that talks about issues related to healthcare and social justice. And we use like a partnership model with our partner SAW, Social Action for Women and Children, located in Thailand, which Emma can talk a little bit about.
Yeah, so SAW is located in Mae Sot, Thailand. It's based in Mae Sot, Thailand, along the Thai-Burma border. It was founded in 2012, and we've been partnered with them since 2011, so about 10 years. So one of the main things that we specifically like to fundraise is the Community Health or Outreach Program, or CHOP, which trains peer educators in the community, and it basically just promotes health education among Burmese migrant workers. So each year we like to donate or fundraise and raise about $10,000 for our partner, so they can help run the programs that they need.
So usually our meetings are on Sundays at the AACRC from 6:15 to 8, and we do like a presentation about each week about different topics in healthcare, such as like last week we did one on vaccine hesitancy. So we'll have presentations and discussions and so on and so forth. We also do events on campus like tabling, and we work with local communities along with our global partner. So that's just some of the things that GlobeMed is involved in.
Yeah, if you guys aren't already in our GroupMe, you can feel free to scan it right now. Our next meeting is this Sunday.
All right.
All right.
So we're going to get into Dr. York's presentation.
Yes.
All right. All right. Did you want to? You could also control the presentation from.
Okay, yeah, I just had some minutes on here. But I might need to guide myself a little bit. Okay. Hi, everybody. I'm Dr. Kate York. I am the Director of Global Health Nursing, the College of Nursing, and I'm an assistant professor. I've been with UC about, 9 years as an instructor. I started off teaching in the Master's in Health Administration program out of the College of Allied Health Sciences. And then after I spent a year teaching nursing in Tanzania at a university there, the dean of the College of Nursing came to see if I would run her global health stuff. So it seemed like a great idea. So that's where I've been since then. All right. So my talk is called Community Centered, Global, and Local. So I don't talk a lot about local. Well, my beginnings in community health were local. But really most of my work at this point is in the global arena. And I've just got a bunch of silly pictures in here, just like this one of the Thai students, we were out in the community with them and he was like, oh, professor, get on the bicycle. So he carted me around this village, which was pretty fun. I felt pretty special. So I'm going to talk a little bit about my background today, just to give you an idea of like where my community health perspective came from, and then how it ties in with global health as well. And then what we're doing at the College of Nursing to kind of bring those two things together. And I've tried to label my pictures as well. So this, I'll talk about that in a minute. My dissertation research in Tanzania, and this is just a photo from one of the focus groups we did. So everything was very community focused. All right, so I think my love for community really began when I started working for a federally qualified health center here in the US for the Healthcare Connection. I'd been working as a vascular nurse practitioner, seeing mainly the older population. I love that population, but I was working in a practice that had, I think, 2 doctors who weren't white, and then no staff. It was all white women, and it was very homogeneous. I was really looking for, I have always felt comfortable in a more diverse setting. And I was talking to a friend who was the medical director of this FQHC, and he said, oh, we have an opening for a family nurse practitioner. Are you interested? And I said, yes, for sure. So I ended up doing some work out at Mount Healthy Family Practice at this FQHC, which we saw mainly underinsured and uninsured patients. So these are folks that couldn't get healthcare in the community because a lot of private doctors or even hospital systems, it's hard to get them to accept Medicaid. So I started working there. I was working there a couple years and wanted to go back to school. I really had a lot of burning questions about how people were taking care of themselves. And mainly what I was thinking about was diabetes. I would see like a mom with diabetes come in and she maybe just had an amputation and her daughter would bring her in and her daughter had diabetes. And I also had her daughter as a patient, but she wasn't taking care of her own diabetes. And I just thought, where is that disconnect between seeing your mother lose a leg and you knowing that you might be in that same situation? So that was one of the burning questions I had. When we have burning questions, we go and get a PhD, right? Because you want to answer these questions. And you might be a little bit bored at work. So you think, what else do I want to do? So you end up in a PhD program. So I started looking at the transgenerational self-care or transgenerational diabetes. So from generation to generation of diabetes and what that self-care looked like. So my first year, maybe 6 months or so into my PhD, I was moving along with this question. I just totally panicked. I'm like, what am I doing? I love community. Like I'm looking at something that affects, individuals, and I'm really community minded. So I panicked, I'm like, oh my gosh, I can't do a PhD because I don't want to study that. And in the end, you never want to lose any people from your program, no matter where you are, what kind of schooling you're in. And so it's like, well, just take a little bit of time, stay in the program, keep doing your courses and decide what it is you want to do. So I started looking at global burden of disease. A bunch of studies had just come out. And I don't know if you guys have looked at global burden of disease in the past. The first time they really looked at it was about 1990. So it's been going since then. And it really shows you for every disability, illness you can think of, there's a mathematical formula and it gives you an idea of what this particular disease state or injury is, what kind of burden it is on the society for each country, and it's really fascinating to look at that. So that's what I started looking into. And then I took and it was at that time called International Health. And it was out of this college that we're in right now. And as a graduate student, you had to partner with someone and do a presentation on a health problem in a certain country. So the person that I was partnering with, she wanted to look at onchocerciasis or river blindness, which is a neglected tropical disease. And we decided on Tanzania. And at the same time, I was taking this mixed methods research course. And so I thought, well, I'm really interested in this. There was a program related to that. And there was the program, and I could think of a lot of questions, this inquiring mind could think of a lot of questions. So I did kind of a mock-up or a proposal that I never thought would end up being my dissertation research, but it did. So I plugged all that information about onchocerciasis and the community-directed treatment with ivermectin, which is a program that the WHO and the African Program for Onchocerciasis Control worked with. And I plugged all that in. I was like, this is an awesome study. This is going to be really cool. So my advisors let me do that. I set this up myself. I was just blindly emailing organizations that dealt with onchocerciasis in Tanzania, and Sightsavers International returned my email. And I'm like, oh, we're kind of interested in this. And it was, part of it was looking at why the community did or did not take part in this. Well, the communities took part in this treatment program, but some people in the community don't want to participate. And we're seeing a lot of that right now with vaccination, right? Even with just things as simple as precautions for COVID, some people in the community, they don't want to do that. So this was actually a program where people, once a year, they go house to house. They take a stick, it's about this tall. In the stick, it has 4 hash marks on it. So one is 1 tablet, 2 tablets, 3 tablets, 4 tablets. So depending on your height only, it determines how many of these pills you get. So any endemic area, any area in these communities, or mainly in the different districts and the regions in Tanzania, if they have endemic or this constant presence of onchocerciasis, they had this program initiated. So we wanted to know, why are people not participating? We know why people do, for the most part. It's health promotion, disease or prevention is better than cure, is what it's a saying in a lot of parts of Africa. It's kind of true. So, so we were looking at that, and we were also looking at community health workers. So you were talking about Saul works with basically community health workers, right? So it's the same kind of idea. And there they have community health workers that do a lot with health hygiene and environmental types of things. And but they don't really give healthcare. But if they were participating in these programs and going house to house, or if they were in support of these programs, was that helping the villagers decide whether or not to participate? So that was the kind of questioning that I was looking at. And so it was really cool, because what I didn't know even at the very beginning was that Sightsavers was actually working with the Ministry of Health, the Division of Neglected Tropical Diseases. They were working together on a 4-year strategic plan. So they were hot to get me over there to do this research so I could help inform this strategic plan for the Ministry of Health in Tanzania. Which is when I say it out loud now, it sounds really cool. And at the time, it was just like a panic anyway, because I was just trying to get my PhD done, right? But it was an amazing experience being so community focused. So I worked with 2 communities there. We went, these are some photos. Actually, all except the bottom left one were from my first visit out into the communities. And we did 500 surveys. All the people that I worked with either the government or within the health sector in these communities. And it was so cool. We just get into a community and we had 8 people on the team, and 2 of us would go this way. We would just like 2 go to the north, 2 go to the east, 2 to the south, 2 to the west. And then we just kind of combed the community. And we had the survey. We did about 500 surveys between these 2 communities, and then invited villagers to come in for focus groups. So we could talk to them about, we wanted to talk to separate groups like women, why did you participate in the program? Same with men. And then we wanted to talk to people about why they didn't participate. And so that was really interesting information to gather. And the communities were pretty good about coming. I didn't have a budget for like snacks and, or, give something in kind for them coming. There was really a sense of community, which, we don't see a lot of that here. We do in kind of smaller, maybe more rural areas, but we definitely are lacking that community like cohesiveness here. So that being said, that was my kind of dissertation work around community. And when I finished that, I started teaching, as I said, in the Masters in Health Administration program, and I was working on a global health conference here at the university and looking for somebody to be a keynote speaker when I found Seed Global Health. This guy that we ended up having come in, he was an advisor for Seed Global Health, which is an NGO. At the time, they were partnered with the Peace Corps, the US Peace Corps, and PEPFAR, which was the President's Emergency Relief Fund for AIDS, and PEPFAR, or for AIDS relief. So PEPFAR had a lot of funding. It was started by George Bush, the second George Bush in office. And it was really an amazing program. So it was a lot of money given to mainly low-income countries so that they could work on reducing their burden from HIV/AIDS. So the PEPFAR people, the Peace Corps people, and Seed Global Health worked together to send nurse educators and physician educators to Malawi, Uganda, Tanzania, eventually Sierra Leone and Eswatini, which was Swaziland. So we had people in these 5 countries. So before I even asked that guy to come be our keynote, I applied for that program. Of course, I didn't tell my husband because I'm like, I might leave for a year and go teach Tanzania. But that's what ended up happening. So he was very kind to be all right with that. But doing that, it really, between doing my dissertation research there and then doing this teaching there, it really started solidifying what my philosophy was around global health. And I went there, I taught the 2014-15 academic year. That's when I was teaching at a university in Tanzania. So I saw a lot of things while I was teaching there, while I was doing my research. I was very much enjoying the communities in Tanzania. My students would go out to the community. Here, if you're a nursing student and you have a clinical rotation or even in medicine and allied health science, really anywhere we have to do a clinical rotation, you go for like 1 day a week or maybe 2 days at the max. And there we put all those students in a bus and drove them out to this place. It was like 4 hours away from the college. And they've got their mattress and they've got some cooking supplies and a stove to take with them. And then we just leave them in this community at a health center. And they live in the community for 6 weeks. They work at the health center there, but more importantly, they're out in the community. They're doing a community assessment. They do school health assessments and really just become a part of the community. Communities really embrace that. They love having the students there. So that was a really eye-opening experience for me. It's like, wait a minute, my students are going to be gone for 6 weeks. But we went out and we were only allowed to go like every other week. So unlike here where parents would be up in arms, right? If their kids were dumped out in some rural area for 6 weeks, this is just the way things are there. So, and they weren't in danger. The community really did just envelop them, and it was really beautiful. So from that, obviously it was such an amazing experience teaching there, but other things that I saw there when I was in a hospital setting, mainly because in Dar es Salaam, which is a big city, there were a lot of gap year students, med students, high school students who didn't even, I guess they had just finished high school and they weren't sure what they wanted to do, but they were able to go to Tanzania for 6 months, 3 months, because there are companies out there that set up these experiences for students, and they're pretty expensive for students. And I don't know if any of you have seen those out there, but they I think sometimes, like, I don't know, normally they have something in their name like gap year or healthcare experience abroad or something like that. So anyway, the bottom line is that there were tons of people there who had no idea what they were doing. I mean, they weren't healthcare professionals whatsoever. I was living in an apartment in Dar es Salaam, and some people who lived next door, some young kids, I think they're from Denmark. They came over and they're chatting and they're talking about, yeah, it was really uncomfortable because, we go there overnight because the nurses go to sleep and they let us deliver the babies. I'm like, wait a minute, what? Like all the air goes out of you. They're like, you've got to be kidding me. Like, you've delivered a baby. Well, we can wake them up if we have a problem. I'm like, well, you have a problem. Like, you should never, it's just so completely unethical, right? And I had seen a little bit of this when I had been in Tanzania before. I was there in 2011 to do this dissertation research, and I had seen some people out not in the villages, but always in a town or something, because it's really difficult to get access to a village. So you're not going to see very many like white people or foreigners of any type who are out in the rural communities in Tanzania. But I saw a lot of that, and it was just, you just didn't want to be affiliated with that at all, right? I didn't want anybody to think I was there doing something, practicing out of my scope. So again, that was kind of bringing this philosophy that I had together. And then again, patients, they might want to see the white person who's there because there's some, I don't know if it's conditioning over generations that the people who come are going to help, and that they've got knowledge and they can actually help you. And it's so wrong. A nursing student from the US doesn't learn how to deliver a baby, right? That's a nurse midwife learns how to deliver a baby, or a physician learns how to deliver a baby, right? But if you're a medical student, you don't really have a lot of skills to do that. If you are like pre-med, you definitely don't have any skills to do that, right? But then the population there might think that you do, or somebody that is in the healthcare system there might say, this person's delivering your baby and you don't have a voice. There's no autonomy like we have here. We can decide, right? And that doesn't exist there. So those are just some of those things that's like, kind of finding these things out is a little bit life-changing when you're there. It really makes you think a lot. So then the other thing I want to say about this is that, and this is just a piece of advice, and it's what I've let happen to me, and it's let the world change you. Instead of thinking like having this, we have white savior, we have to help everyone. It's more like let the world change you. So you go, you don't have the skills, you as a person can't change something in that country or in that community outside of your own, right? So it's kind of like that step back and learn about it. Then maybe when you're a healthcare professional, you can go with, you know, and try to work within the health system in that country and help make some changes, which is what I love about what I'm doing with Seed Global Health. Right now, I'm still working with them. I'm their Associate Director of Primary Healthcare and Community Health. And so we're not with the Peace Corps anymore. Well, politics gets in the way of a lot of things, a lot of good programming. So it went away. Our CEO is Vanessa Carey, who's John Kerry, who was our Secretary of State under Obama. His daughter Vanessa runs Seed Global Health. And so when there was a new administration that came in, then there was a lot of fractioning and things that happened. And so we could no longer have this contract with a government agency, which was the Peace Corps. So you'll find that as you work, you might have already seen it with things, you know, the difficulties just like with governments, right? And you know, the reason that you're doing work with SAW is because there's a problem in Myanmar, right? So politics affects global health in a huge way and communities in a huge way. So once I came back to the College of Nursing, we were trying to decide what it is that we wanted to do. I told the dean that I was not interested, I wasn't interested in medical mission trips because so even, I mean, there's some really good medical mission trips, don't get me wrong. And like Village Life Outreach, they do all kinds of things, but they also have a brigade once or twice a year. And I love their philosophy and I love what they're doing. They're very incorporated into the community. So I'm okay, I'm excluding them. But for the most part, I just thought for teaching students, the best thing that we could do is have them involved in the community, not going and thinking, you know, that I need to take 40 blood pressures or, you know, I want to be part of filling prescriptions for people, especially in countries where you can't speak the language. You know, that's, again, it's hard to be helping your hands, but you're not like helping, you know what I'm saying? So the dean and I had an agreement that we were going to shift from medical missions to partnerships in the community or in the countries that we were going to partner with, and that we would do this with a community clinical rotation. So we totally changed this. So at first we were starting with, when they were doing the medical missions, they do maybe 3 meetings before the trip. So they weren't really learning about the country or the culture. They were just talking about their roles with the mission trip in general. And that was really problematic for me because what about when you get there? Like you can't say hello to somebody because you don't speak the language, any of the language. You have no idea what's going on with the politics or the economics or poverty rates or, you know, what's going on with safety and transportation, what's our health system look like, right? These are all things we want to know when we're going to, what do you want me to do with this? Enable that? Okay. All right. So I created these pre-departure trips or prep classes. So for an hour and a half or 2 hours every week, we learned language. We figured out how to talk about what our needs were going to be and all of the niceties, you know, greetings and things like that. Ordering food, knowing the local names for foods that we wanted to have. And the students they always do a great job putting all this together. So we learn about everything about that country. I mean, we even talk about holidays and social norms and family values, and we really get into it because we want to know, we don't want to be culture shocked when we get there, and we also do not want to be inappropriate. That's like a nightmare. So yeah, so that's what we decided we would do, and that we would partner. Our first partner was HKMU, Kairuki Memorial University in Dar es Salaam. That's where I was teaching. So I knew the faculty there, I knew the dean there. That was like low-hanging fruit, right? So we started having some community clinicals with them. So we didn't go for 6 weeks. That's really difficult for US students to do. So at the end of our semester, we go out into the community for 2 weeks with the students. So they're there for 6 weeks. We just go for 2 of those and sleep on the floor in a house by the health center, use the squatty potty, whatever the community is using, that's what we're doing. We go to the market and get our food. A lot of times we hire someone in the community to cook for us. Sometimes they do our laundry if we pay them. So it's a nice way to incorporate people. The Tanzanian students, they take our students around, they do home visits, they do community assessments, they go to the schools with them, they're in the health center with them. And so, as much as the community embraces the Tanzanian students, they start to embrace the US students as well. And that's such a good feeling to be part of that. There were 2 students when I was doing my PhD, 2 PhD students from Thailand. So they both work with the Boro Mara Jonani School of Nursing in Thailand. So one is in Praputivat and one is in Saraburi. So this is kind of central Thailand above Bangkok. So on your way north. And we do the same kind of thing there that we do in Tanzania. Normally there, though, we stay in the dorm because those students are in a community that's like 30 minutes away, as opposed to being in Tanzania, sometimes we're as far as 8 hours away from the university. So there we usually stay in the dorms, but we meet up with the students every morning. The students are paired with our students are paired with a Thai student. And so they work on language, they are going to the community, they're helping, teaching each other different things. Our students love like natural remedies for things that the Thai students are doing out in the community. And our students, last time we were there was January 2020, and right before the pandemic. So we haven't been anywhere since then. But when we were there, our students were in a house with some of the Thai students and with this older couple who lived there. And they were trying to transfer the patient, the older woman. And our students were like, oh, you need a transfer belt. And so it's not like something we use all the time in the hospital or use, nursing homes and things like that. It's like, so they got a scarf and they showed how to use it as a transfer belt. So it was this really great exchange of knowledge that we have going on. And then I wanted to bring up Chiba University. This is new for us. It's an exciting new program because we've had COVID and nobody's been able to go anywhere. We've been doing a collaborative online intensive learning set of modules with undergraduate students. And this last year, what we were looking at with them, we had 5 students, they had 5 students, and they looked at different health equity issues around COVID. And so this was really, they did it in February, so there wasn't any kind of giant rollout yet of vaccines, but they were looking at the disparities both in Japan and the US around that. And so just comparing these two cultures and two health system responses. So that was good. And we're trying to do it again for this year. And again, students love doing these when they can travel. So sometimes it's hard to get students interested in doing these if you're not going anywhere. And I would imagine that you guys have the same issue, like, GlobeMed. So I was surprised last year, my global health course didn't have enough students to run. And I'm thinking we're in a global pandemic, but then we didn't get to go anywhere. And so I think that's a lot of the pool. And I think too, people were just inundated with, they had a lot of information last year about COVID and healthcare across the globe. And I think there was a certain saturation to that. All right, so just one more quick point is, so my work with SEED Global Health is varied and it's quite interesting. And I wanted to bring up one of the areas where I work, which is at St. John of God College of Health Sciences. They have this cool program. They've got a bachelor's degree in psych mental health nursing. So here we just have a bachelor's in nursing. And there they have this specific bachelor's in psych mental health because it's such a neglected area. It's really hard. I think Malawi has, maybe now they have 3 psychiatrists for the whole country. It's 18 million people in Malawi, so it's not 330 million like the US, but still 18 million and 3 psychiatrists, that's a problem. So the ministry understood that and they encourage development of these nursing programs. There are 2 programs in the country that do psych mental health nursing. They also have clinical officers. So these are people who, instead of going through the university system, they learn a lot of primary care. But this particular place, they do training for mental health counseling. So they're putting out a bunch of these mental health counselors as well. And then they have a medical degree. So in other countries, you might know you don't go to medical school after you do a 4-year degree, you just go, right? I think it would be nice if we incorporated that as well. But they, so they have a specific training of, you're like a medical doctor of mental health. So you don't do the standard one and then get a master's in a specialty, which is that's what normally happens in other countries. So they're just specifically a medical doctor for mental health. So they're trying, but they're not like, they haven't had enough training to be a psychiatrist. So, but we're working with them because they really want to put mental health out into the community. And the problem everywhere is trying to get people to go to rural areas. It's the same in the US. You don't have a lot of providers out in rural areas because you don't get the kind of pay, the amenities that you'd like to have aren't close by. And they're not quite at the level of telehealth that we are. So it makes things difficult there. So I love this picture so much. This is one of my students, Haley, and then Albert, he was the kind of the class president for the Tanzania group. And we were doing a home visit. This is one of the homes in the community that we were in last time we were able to go. And, the community members are excited, they feel proud. There's a lot of pride for them if they're selected to have a family health assessment done. They're so proud. They just think, it's going to increase their status in the neighborhood. Unlike here, if you go do a family health assessment somewhere, like people are like, I don't want anybody to see that there's a public health person coming in or nurse coming in. So I know I kind of blew through a lot of topics there, but I just wanted to kind of give you this, like my sense of community, where that kind of came from. And I'm happy to answer any questions or just let you get to your discussion questions, whatever you'd like. Yeah.
So what's the family health assessment? Like what exactly?
Oh, great question. So what's a family health assessment? So when you are a community health nurse or maybe even a community health worker, you go in and you just look at all these aspects of the family, and you do it with more than one family member. So you get all the perspectives. You know, kids can't really, little kids aren't going to give you a good perspective, but you look at their resources that they have. You look at the family dynamics. You look at the economics of the family, you look at the power structures that are involved in the family, and a whole lot of other things, just pages of questions. And then you make diagnoses off of that. So you list the assets of the family and then the challenges that the family might have. And then you can make diagnoses off of that, like family health diagnoses, and then plan your interventions and evaluations from there. But it's like, instead of taking care of the patient, you're actually taking care of the family. So we do those abroad and we do those here as well. Yeah, great question. Yeah.
Can you explain what drew you to international and global communities as opposed to like domestic communities?
Yeah, that's a really good question. I don't know. I think maybe because I grew up in a low resource family, I think that I had kind of, maybe I've been there, done that sort of thing. Maybe that was too close. And then I just wanted to, I have a very inquisitive mind. I want to know everything. And so I think that finding out what happens over here and, maybe using some of that information to determine what we do here in the US. I think that that's it. I don't know. No one's ever in the years I've been doing this asked me that question. So I haven't thought it through, but I think, I might say that it was just a little too close to home. I wasn't really fond of that. So I think working in it here, although I did work in the low resource health center and I liked that a lot, but it was also, really different race and ethnicity from what I grew up in. Yeah. Other questions? Any online? No. Okay, great. Thank you so much.
Is there a way? Sorry. Wait. Oh, there we go. All right. So this one.
Breakout rooms have been made online. They're free to join any time. Dr. Lee has joined. I have the center to.
Did you have your mic on? Did you have your mic on? Did you?
Hi everyone, you are free to join your breakout rooms. Everyone has been assigned. Feel free to answer all the questions or just discuss a few, whatever you're comfortable with. And we will meet back in about 15 minutes.
So feel free to break out into a few groups and discuss the questions.
All right, everybody, we're going to come back into the main room so we can go to Dr. Lee's presentation. All right, Dr. Lee will be starting her presentation soon, so, okay. Whenever you're ready.
Hi guys, can you hear me okay? Can you hear me?
I think we can hear you, Dr. Lee.
Okay, great. So I will start my presentation. Thank you for having me today. Today I will discuss my research project, the Most Diabetes and Health-Friendly Pantry Shelves Initiative. Before I talk about my research, I will introduce myself briefly and provide some background information which can help you understand my research project better. And then finally, I will present my research project. So I'm originally from Seoul, South Korea. I got my bachelor's and master's degree in food and nutrition at Sookmyung Women's University. And then I came to US in 1999 to get my PhD in human nutrition at Michigan State University. I completed my 3 years of postdoctoral training in the same place. And then I got a job at UC in 2008. So since then, I have been working at UC. So the reason I selected nutrition as my major was mainly I like science and also I like working with people. So I thought nutrition is the right major. Science-based information can be used to help people eat better and eventually improve their health as well. At UC, as a tenure track faculty, I am supposed to do research, teaching, and service activities. And through my activities in research, teaching, and service, I have been trying to address health disparity, food insecurity, and nutrition. So I'll briefly share what I'm doing. So first of all, regarding teaching, I teach 4 classes. 2 classes are service learning classes. So actually prior to the COVID-19, so community nutrition and nutrition education for behavior change, those were service learning class before the COVID-19 pandemic. So basically, students completed their final project, which required the students to develop nutrition education class and then go to community setting, providing nutrition education, mainly targeting food insecure population. So this is one way I try to address health disparity in community while I'm working with my students and teaching them. And secondly, my research activities. So these are the research interests of my research interests, so including food insecurity, health disparity, food literacy. So basically, I try to help people, especially underserved population, to improve their health through nutrition education or nutrition intervention, so they can improve their eating behavior as well as they can manage dietary related chronic disease better. And currently, these are my projects I'm working on. So currently, I mainly focus on helping African American adult. So my current main project is developing graphic style story-based intervention to improve health literacy in breast cancer survivors, particularly African American women. And the other one is also we engage for health projects. So you can see this is the characters we are using for graphic style stories and try to help people have a better understanding of different topics of health. And I'm contributing to the group in terms of a nutrition aspect. And another project I'm working on is developing a prototype telehealth drone. So I'm working with several faculty in other fields, engineering, nursing, and health informatics. And we try to develop a prototype drone which can be used to provide telehealth, because some people, especially rural area or underserved area, they don't have a great access to healthcare, and they don't have a digital device they can use to use the telehealth. Also, they don't have internet access. So we try to develop prototype drone which can be used to provide telehealth. So these are my research activities, which also try to address health disparity. And then finally, one of my service activities is to serve as a faculty advisor for UC NutraEd. And this is a student organization trying to promote healthy eating in this community. And we mainly working with the St. Vincent de Paul and provide a regular nutrition education to food pantry clients over there. So we were very active before the pandemic. Nowadays, we only provide the online nutrition education. So again, through my research, teaching, and service activities, I try to address health disparities in the community. So that's it about me. And so as I mentioned earlier, I want to provide some background information before I talk about my research project. So how many of you are familiar with food insecurity? Anybody? Or have you heard about food insecurity? Okay, I see some some hands. So, but when I talk to some people, they often confuse with food safety, and they think food security is the same as food safety. So for those who are not familiar with food insecurity is defined as the uncertainty of having or unable to acquire enough food to meet the needs of all household members because they don't have enough money or resources. In the US, we measure food insecurity using household food security survey module composed of 18 items. So the measurement is at the household level. That's why you see here household members in the definition. And based on the survey score, food security can be categorized into 4 different levels: high food security, marginal food security, low food security, and very low food security. And food insecurity include low food security and very low food security. So you can see here the difference between low food security versus a very low food security. So regarding low food security, there's some compromise. So quality and variety and desirability of a diet is compromised, but quantity of the food intake hasn't been disrupted that much or changed that much. But when you see very low food security, of course, the quality, variety, and desirability of diet is compromised, but also people cut down their amount of food consumption. So that's the big difference between low versus very low food security. Based on so this measurement, what do you think the prevalence of food insecurity in the US? So low food security and very low food security belong to food insecurity. Can you guess what % of household in the US is food insecure? Any idea? So I see somebody put on the chat. Let's see. 20%. Anybody else? So in 2020 data, it shows over 10%, so 10.5% of US households were food insecure, including both low food security and very low food security. In terms of Ohio, our prevalence is slightly higher than national average, 11.6%. So yeah, it's not, somebody said here 20%, but it's not like that high, but it's still a significant problem in the US we should address. And for those who are curious about our local prevalence, I add also the prevalence in the Hamilton County, so 7.2%, pretty higher than compared to the national average. And in terms of Cincinnati, 1 in 7, so this is about 14%. So this data is from USDA website, and these two values are from Feeding America website. So again, my point is food insecurity is a significant problem in our community, and it should be addressed. So what kind of health outcomes do you think we can expect from food insecurity, or maybe eating behavior or dietary quality? Any thoughts? So they tend to, so if in, we don't see malnutrition in the US that often. So if you go to third world country, you can see their height and weight is significantly lower than normal growth chart. But in the US, some maybe show malnutrition, but often, well, maybe if obesity also included in malnutrition, yes, obesity is one of the issue in food insecure population, particularly women, and their food intake is poor in terms of dietary quality or nutrition aspect. So tend to consume higher added sugar consumption or higher consumption of saturated fat. Their consumption of whole grain, fruit, and vegetables are low. So that's some concern that relate to food insecurity. So my research project I will talk about that's related to this health concern. And then I want to briefly talk about community-based participatory research. Have you heard about CBPR before? Anyone? Not really. So this is an approach, so collaborative approach to research that emphasizing equitable involvement of all partners in the research process. So if we work with the community partners, if we use this approach, we should include the community partners' input from the beginning of the process to the end. Traditionally, when you see the research project, researchers go to the community and then try to address the issues in the community. But if people who are using CBPR approach, they get the input from the community and then decide which problem they want to address. And then when they develop intervention, they also work with the community members and try to address the problem. So why do you think maybe this CBPR approach is important to use in the community setting? Any thoughts based on this definition? Any ideas or thoughts? So these are why. So first of all, we can address the needs of the community because we work with the community members and we get the community members' input. Secondly, when we develop an intervention or program, because we get the input from the community members, it's more acceptable or relevant to the community members or to the community. Finally, the program can be more sustainable or the intervention can be more sustainable. Often, if we do traditional research and develop intervention, after a research project is done, the program is gone. Because some program is very intensive or requires more expertise or expert to implement the program. But if we get the community input, we are more likely to develop sustainable intervention. That's why often CBPRs are recommended to use, especially if we work with the community to address some issues in the community. So I use this CBPR approach to complete my research project here. So the title is The Most Diabetes and Health-Friendly Shelves Initiative. This is a collaborate effort with the food pantry affiliated to Jewish Family Service. Before this project, I didn't know anybody from that food pantry, but I happened to meet the food pantry manager at one of the CCTST community event. And we sat in the same table and she talked about her concern regarding her food pantry clients' health issue and her pantry clients, even though she provided some healthy options, they don't really use those healthy options or they don't select. So I told her, maybe I can help you. So after that, that event, we met again and discussed how we can work together. That's why, that's how we initiate this project. So first of all, we formed a project team. And project team, as you see here, include a research team, so my graduate student and me, and community members, including food pantry manager, staff, their volunteers, and a client who was actually using the food pantry. And we actually met lots of times, multiple times, to try to figure it out what we want to do. And then finally, this is our final product, like the most diabetes and health-friendly shelf initiative. So the goal was to facilitate food pantry clients to choose a healthier food option in quick and easy way. Originally, I proposed, yeah, I can provide nutrition education to your client. But they said, oh, that's too much, because they weren't sure whether all the clients would attend my nutrition education class. So this is what we had at the end. So are you familiar with the choice food pantry versus traditional food pantry? Do you see? So traditionally, food pantry, they provide prepackaged food items in a bag or a box. So this doesn't consider any preference of food pantry clients. Nowadays, the trend is they try to switch to choice food pantry. So if you go to choice food pantry, you can see the structure look like a grocery store aisle, right? And based on the household size, each client can have a certain amount of food or certain number of food items in each category, each food category. So based on their preference, they can select what they want within the food category. So as you see here, and there are some options. Did you get the concept? Can you see the difference, right? So if you see the Jewish service food pantry, these are the food items they have. So they have this kind of food categories like fruit, vegetable, applesauce, dairy, grain, protein, and snacks. But for our initiative, we only select several of these food categories to initiate this green shelves. So basically what we did was, so you can see this is a section for canned vegetable, right? And based on the our guideline to be qualified green shelf items, if some items are met, this kind of requirement, we place healthier items in one section within the food section. For example, let's say there is a canned vegetable section, and we divide the canned vegetable section into two sections. One, green shelf section, so healthier item, and then the other part, rest of those choices. And then put green tape to identify this is a healthier option within canned vegetable section, and put the magnet so people can easily see, okay, this is a healthier item. So we only did with canned vegetable, canned fruit, applesauce, and cereal, bread, and rice. And these are the qualification to be placed on green shelves. So this is a magnet we use, most diabetes and health friendly. And then we also put posters on the wall so people can see what we are doing. And then we also distribute the brochure during the intake process. And you can see the brochure include what's the benefit of eating this kind of items placed on the green shelves. And then the other thing is we also include directions to rinse canned items. And I know many of you may have been to food pantry, possibly, maybe not, but because of the storage issue, they often try to have items which has long shelf lives, right? So often they have canned items. Some concerns with canned items are high in added sugar or high in sodium content. So in order to remove some sodium and added sugar, we encourage people rinse those food items. So these are what we distributed. So that's the intervention. And then we implement the initiative. first of all, we trained volunteers for two purposes. First of all, they should place right food item on the right shelf, right? Whether this is qualified for green shelf or not. Secondly, when their client have any question, they should be able to answer. One thing the food pantry manager emphasized was every food choice should be respected. We cannot force them to use this green shelf. So we train volunteers. You cannot just force them to select food item from the green shelf, but you can just let them know this is an option and why we are doing this kind of this initiative. So we provide training, and at least one graduate student were at the food pantry to help volunteer to stock food items on the right section. If they didn't do, they put on the wrong section, my graduate student, they just place in the right place. So we did that and then implement the initiative. And then 8 to 11 months after the implementation started, we conduct survey with 50 clients. And then we also conduct 13 in-depth interviews to evaluate client perception, acceptability, and then potential impact of this initiative. So what we found, first of all, is here, green magnet, and volunteer shoppers. Those two were the main things to increase awareness of green shelves. So 28 participants reported because of a green magnet, they pay attention to the green shelves. And then 11 participants said because of a volunteer shoppers mentioned about this green shelf, they were aware of having this option. But poster and brochure, it didn't work. They didn't work very well to increase awareness of the shelf initiative. And then we have a long length of survey, but I just included 2 tables from the survey result here. So we asked them actually whether they selected food items from the green shelves. And these are the results you can see here. So actually majority said they select items from green shelf, canned vegetables or canned fruit, always or sometimes, you can see here. But when you see whole grain, bread or cereal, less participants reported that they selected items from the green shelf, always or sometimes. And then we also ask whether this initiative will help them change any certain behavior related to food selection. So unfortunately, we couldn't do pre and post test. So this is a cross-sectional study, and we just asked them to perceive their change. So we actually didn't measure actual change. So keep in mind that one. So the wording we used in the survey was here: how did having the most diabetes and health-friendly food pantry shelves change your food selection? So we want to see whether they have changed during shopping at the food pantry versus at the grocery store. Because at the food pantry, they have green shelves. He had green shelves here. Oh. And you can see here, 44% of people said they start checking nutrition factor label at the food pantry, but 50% of the participants reported that they start checking nutrition factor label at the grocery store. And also you can see they start selecting low sodium options or low sugar food items as well. And selecting more whole grain and more fresh produce. So definitely, even though this is not done with a pre and post test, at least they reported that they have changed this kind of food selection behavior. And then we also did 13 in-depth interviews. Are you familiar with the in-depth interviews or qualitative research? I think one nod your head. Anybody else? Yes, I think some people said yes. So if you are familiar with the qualitative research, I will just show you some questions we use. So when we do qualitative research, we use open-ended questions. So semi-structured open-ended questions to really explore the perception of the participant. So the key question we used are like these. So ask overall impression and how the initiative helped them to influence their shopping and food selection at the food pantry and also at the grocery store. And except these kind of food selection, what else? What kind of other changes they had they made? They made. And then even though we didn't really focus on diabetes self-management through our initiative, we just include the wording diabetes, how they have changed the diabetes self-management or other kind of conditions. So we ask this question and then whether they have any suggestions. So what we found was, so in terms of qualitative research, we report themes, sub-themes, and then also some example quotes relevant to the sub-themes or themes. So this is one way to present qualitative research. So you can see these are the themes, what we found. So the primary determinants of item selection, often nutrition value, brand name, and transportation. So I didn't really expect having this transportation, but often food insecure populations, they have a limited transportation and often they use public transportation. So if the items are too heavy, they cannot really carry those items. So that's a big factor when they select food items. And then in terms of green shelves, what's their impression? So they like eye level placement. So when we place the healthier item, we try to put all those healthier items on the eye level, not too high or too low, so they can just immediately see those items and they like it. And then they think it's very convenient because we just said that this is a healthier item compared to the rest of the option within that each food category. And then in terms of using magnet and green tape was visually appealing. So that was the impression. And then in terms of impacts, so this is consistent with our survey result. They have increased intention to read the nutrition fact label and then purchase more healthier item, especially low in added sugar, fat, or sodium. And they tended to rinse canned fruit and vegetable because we provided that brochure to promote rinsing those food items. And then in terms of impact on diabetes management, actually a couple of them mentioned that they reduced A1C level and they are more frequently monitoring their blood glucose level. So even though we didn't directly address diabetes self-management, there's some impact here, as you see here. And then in terms of suggestion, several mentioned maybe we could expand the shelves to other categories because we didn't include all the categories when we have this initiative implement. And the other one is maybe we can also provide some recipes or additional educational materials. So even though we provide the brochure, maybe that's not enough. And then lastly, some people thought because it has diabetes, it's not relevant to them. So they just passed. So they said, maybe remove the diabetes or change the order. So instead of saying the most diabetes and health friendly, we can say the most health and diabetes friendly. So they can see health first. So those are their suggestions. And so as a conclusion here, obviously this initiative are receptive to the pet clients and has some potential to improve their food choices especially when they shop at the food pantry as well as at the store. But because this one was not done with a pre and post test design, so in order just to say this is effective, we should have experimental study design, including pre and post test, also incorporate control group. That's the conclusion and implication. So, and this is the acknowledgement. So my graduate student and another faculty who was involved in this project, and then also all people in the Jewish Family Service Food Pantry. And then this one was supported by CCTA Partnership Grant. Do you have any questions so far? So I asked to also mention what kind of advice I have for people like you who are interested in community health. So one thing you can do is several things actually you can have more experience in community health is seeking volunteer and research opportunities. Have you been involved in any research project related to community health? Anybody? Some of you, that's great. So I think a research project can give you good insight, how you can work with the community, what kind of research can be done to help community members. And then if you are a student at UC, there are some service learning classes or honored seminar courses which address community health. So possibly you can take those classes. That's another my recommendation. And then when you work with the community, I hope you work with the community. And often people say that I work for a certain population or work for certain people, but I think it's very important to empower community members. So even though you can help some aspect of to resolve some issues in the community, if you can work with them and empower them, that can be more, has a long-term effect. And then lastly, if you work with a community who have different background or cultural background, or maybe you can make some efforts to increase cultural competency, that's very important. And I know you guys already discussed before my presentation. So possibly you can do that. So what kind of questions do you have? Any questions?
I have a question.
Mm-hmm.
Sorry, in terms of the impact on the students at UC for their health, what have you seen, like in terms of like food insecurity, like what have you noticed at UC?
Okay, so actually one of the faculty I'm working with, Dr. Rebecca Lee from nursing, she got a grant and I am co-I for the grant. So we will do one food insecurity project with a UC student. So we'll assess whether current food insecurity assessment tools are relevant to college students and what kind of experience they have, the kind of things. And in terms of food insecurity, there's a food pantry at UC, Bearcat Food Pantry. Are you aware of that? Bearcat Food Pantry. So I know some UC students, they have issues with securing budget for food, so they can get some resource from UC, especially Bearcat Food Pantry. But during the pandemic, since they are not coming to school, I don't think they seek that opportunity to get some help from Bearcat Food Pantry, but that's an option. But when I talk to my student or during the class, I often ask about this issue, and then they said, yeah, sometimes we don't have enough money, or I don't have enough money. I work as a part-time, I should pay my bill. I don't live with my parents. So they are very honest. Yeah, I'm food insecure. In previous years, I had a student who are using SNAP, new name for food stamp. So college students, some of you are eligible for SNAP. So if you are in difficult situation, I encourage you to check out the eligibility for SNAP as well. And then here, there is a question from Somia. Here, okay, when you include clients of food pantries to develop the project, how did you take into their consideration? So while we are doing brainstorming, so there was only one client involved in this project when we designed this project, but we discussed some ideas, okay, how we can identify healthy items, and then I suggest maybe putting the sticker, and then the pantry coordinator or staff, they said that's too much, putting the sticker, so that idea was out. And then we actually had the 3 categories: best option, like a middle, and then regular, more like the rest of the less healthy option. And when we talk about this option with the volunteers, they said it's too much. We cannot really identify, or it will be very hard for them to categorize into 3 categories, and then put into 3 sections of each category. So that idea was out. So at the end, what's the simpler way to do it? So, okay, 2 sections of each category. And then when we discuss the name, there are multiple names. I cannot remember all those names, but at the end, they kind of vote, okay, this is the best we like. So that's the way we incorporate their input. And also the client, she was somewhat quiet when she tried to make her voice, but at least we asked whether she liked it or not, whether she think this idea would be receptive to the clients, or yeah. So we got feedback through the meeting, through the discussion. What else? Oh,
All right, thank you, Dr. Lee, for your presentation.
you're
We'll
welcome.
go into breakout rooms, so feel free to join those. I will bring out the discussion questions. If you could stop sharing your screen, Dr. Lee.
Sure.
I could pull up the discussion questions. All right, everybody, we'll be back in a couple of minutes for Dr. Irwin's presentation.
am I supposed to?
All right, everybody, we'll be starting with our third presentation soon with Dr. Irwin.
I mean, they're
Dr. Irwin, you have screen sharing abilities, so you should be able to share your presentation.
Okay, thank you. Can you see my slide?
Yes.
Yes. Okay. All right, you tell me when you're ready for me to start.
Whenever you're ready, Dr. Irwin.
Okay. All right. Well, welcome and good evening, everybody. So I am Amber Irwin, and I currently work as an assistant professor at the College of Nursing at UC. Go Bearcats. We got a football game coming up tomorrow, so I'm excited about that. Big supporter of my Bearcats. So I am going to share my story with you this evening. So when the young lady came to me and asked if I would be interested in sharing my personal story with community, the way that I have been involved in my life with community nursing, and I said, absolutely. It's always important to me to share my background and my love for community nursing. And so I hope that after watching my presentation, that maybe you might be interested in community nursing as well. Okay. So the title of my presentation is Community Nursing in Rural Ohio. So first off, I'm going to explain to you my career path and how I developed my interest in community nursing. So a lot of that comes from my childhood experiences. I came from a disadvantaged background. I was born and raised in West Union, Ohio. I'm not sure if any of you are familiar with where Adams County is located, but we are about an hour and a half southeast of Cincinnati, where the University of Cincinnati is located. And that is if you're not experiencing rush hour. If it's rush hour, then you're looking around 2 hours to get to my hometown. So most of you are probably sitting there and saying, why in the world would she want to drive to the University of Cincinnati? And it's because of my love for community nursing, mental health nursing, and my students. I really fell in love with it, and I hope that my story will speak for that. So Adams County, specifically West Union, Ohio, where I live, is the county seat of Adams County, and there's a population here of about 3,241 people. When I grew up, our household income met and exceeded poverty standards. However, here in a minute, I'll go on to further explain. We were a family that grew up in poverty. However, we did not meet the guidelines that would give us any type of help or support from the community, or no type of Medicaid services. So we didn't qualify for that, yet we made just enough that we also couldn't afford healthcare and some things of that nature. So we used the emergency department for most of our healthcare concerns. When I was growing up, I had no access to dental care until I was of age. I was 18 years old and married before I ever had access to a dentist. No vision screening except when I was in school. They done the vision screening in school, and so I had access to that. But other than that, no outside, visits with a vision checkups along the way. I grew up eating fast food most nights of the week because it was cheaper, obviously, than your fresh produce. And so also for the time wise, it was easier because I did grow up in a household with a single mother. So it was easier for her time wise, because she was trying to work, to go and get fast food. And so it did result in a personal obesity story that I had for many years as well. I suffered from anxiety that resulted in generalized anxiety disorder diagnosis, and that developed from the time I was a teenager until I was of age, and was able to seek care for that as well. Now, as for my adult experience, because what I've explained to you thus far has been all of my childhood experiences that has led up to how I developed my passion for the career path that I chose. The adult experiences that I had included wanting to make a difference in rural America, in my hometown, where several other individuals like myself suffered from poverty and obesity and a lack of healthcare options. And so I decided to become a nurse. It wasn't my first career choice, to be honest. I was interested in technology and thought I wanted to be a computer programmer until I started school. After I got the first 2 years done of general education classes, I decided that technology was not for me and that I wanted to pursue a nursing degree, again, to make a difference in my hometown. I got my associate's degree from Shawnee State University and started working in critical care in 2002. I thought that's what I wanted to do. I liked a fast-paced working environment until I got into the real world experience in critical care and found out real quickly that was not for me. So I went back for my BSN at Shawnee University as well and finished in 2007. And that is when I lucked into my community nursing experience. And I say lucked in because I had no idea that community nursing was something that I was interested in. It just happened to be that I wanted out of critical care so terribly bad that I put in my resume at several locations, and I was called by a local WIC and family planning agency in Adams County, Ohio. It's an agency called ABCAP, and that's Adams, Brown, and Brown Counties Equal Opportunities Incorporated. And within that agency, they had a WIC department, which is, most of you probably know, it's women, infants, and children, services that they provide to women and children that need supplemental food for their infants as they are aging. And so I worked in that department and found out that I absolutely adored working in community nursing. WIC was right up my alley. I got to work with children, which was something that I had a passion for, but also working with clients that are well, okay? And we'll talk about that in a minute, how I developed my passion for that health promotion here in just a second. I also worked in a women's health clinic while I was at that same agency, who also offered services for women that came in that didn't have enough money or health insurance, but they also needed access to their annual pap smears and services of that nature. So I got to work in that area as well. I worked in that agency for about 3 years, and I probably would have retired from there until I got a call from the local health department asking me if I would want to be placed in a school in the Ohio Valley School District where I'm from to be a school nurse. And it was going to work great with my schedule, not to mention I had a son at that time, so it was going to be perfect for his and my schedule both. So I took the position. The way that it works here in Adams County, the school nurses are placed by the Adams County Health Department. So I had dual employment at that time. I was working at the Adams County Health Department, but placed in the schools. And again, right up my alley because community nursing, and also because I got to work with children. So while I was working there, the University of Cincinnati called me and asked me if I would be willing to take students, nursing students, and I gladly accepted. I always like to pay it forward. And so while I had those nursing students with me and shared my love for community nursing, I decided to go back and get my MSN in nursing education. And so I did that at American Sentinel University. And quickly after that, after I obtained that degree, I started working as an adjunct instructor for the University of Cincinnati. However, I did not leave my placement or my love for community nursing. I was then put in charge of placing students in the community sites in Adams and Brown counties. And so I brought students from UC out my way. And I got to place them in the local schools, the local health departments, local home health agencies, anything really that offered a community service. And I still do that currently to this day. So my community nursing experience specifically, and I've kind of talked about it along the way, but I kind of want to go back and explain it a little more in depth. So while I was at the WIC and family planning agencies, I explained a few services that we offered, but we offered PAP exams, birth control, height and weight assessments, food vouchers, health promotion education that was all income-based care. So when an individual would come in, if they didn't have any type of health insurance, then we offered a sliding fee based upon their income. And a lot of women in our local area would qualify for a zero copay, which was an excellent service, because remember, back to the beginning of my presentation, a large portion of the population in Adams County is in poverty. While I was in school nursing and the Adams County Board of Health, I switched gears and started doing things such as vision, hearing, BMI, and scoliosis screenings. I got to be part of what I still to this day think is one of the most excellent things I've ever been involved in, is applying for and receiving a grant for a school-based health center that is still in operation today at the Manchester local school district. So while students are at school, they, as long as their parents signed a permission slip form, the students could come down, they could have their vision screenings completed, dental screenings completed. If they were sick, they could come and see the nurse practitioner right there at the school. And it's really awesome because, going back to what I said about people suffering from poverty in this area, they also have a lack of transportation. And so when those parents are unable to pick up their children during the school day, because even if they have one car in the family, one family member is out on the road working in that vehicle. And so no access to come pick up their children. They rely specifically on busing service. So if the child was sick, they could come to the nurse's station, go back and see the doctor, get their prescription. And then our resource officer in the school district could even take them and pick up their prescription and deliver them home with their medication. Really a wonderful service. I can't say enough about it. And that definitely is probably one of the highlights of my community nursing experience. I also provided diabetic care, sex education to students as low as in the 5th grade, health education. So we done CPR trainings. We would do dental education on how to properly brush your teeth, how to properly wash your hands, different education sessions like that I was allowed to do for the students. Immunizations, we would screen for immunizations, and if there was a lack thereof, they could be provided at the school-based health center. And of course, first aid, and then job shadowing, which is again part of where I would allow the UC nursing students to come in and work side by side with me along the way. So that kind of encompasses my community nursing experience. Now, I kind of want to switch gears here for a second. And I want to explain to you my love and passion for community nursing and why, what about it is that stands out so much to me. What I love about it is you're talking about health promotion versus health treatment. Okay, so when you are in a hospital style setting, you oftentimes, most of the time, are talking about health treatment. Okay, so those are individuals that are coming to you sick, ill, or need some type of treatment for something that already exists. Okay, so they have pneumonia and come to the hospital and need to be treated, and they're receiving antibiotics. That's the kind of thing that you're going to see in the hospital setting. Whereas with health promotion, okay, we talk about primary prevention. So these are healthy individuals that are coming to us to seek care to avoid, getting sick. Okay, so these are the things, you're talking about primary prevention and health promotion, whereas with health treatment, you're talking about tertiary care. Also, when you're talking about health promotion, we focus on the social determinants of health. Okay, so we can focus on those individuals that have a lack of healthcare options, and we can provide that care. Those that suffer with a lack of transportation. We work with those individuals that suffer because of social determinants of health. Whereas again, health treatment, we're focusing on the treatment aspect of things. With healthcare promotion, a positive from that is that it involves reduced healthcare costs, because again, if we can tackle the situation and offer screenings and educate the individuals, immunizations, all kind of things that help to prevent illness, then that's going to, in the long run, reduce their healthcare costs. Whereas, you know, if you're talking about health treatment, you have an individual that's in the hospital, they are already sick, they're diabetic, they're having a complication, and therefore they're being treated, that's going to add up those healthcare costs. And then another thing that I truly love about health promotion is that we get to form relationships with our patients. Okay, it really is that that experience that you get to meet your client, you get to educate them, and then they continue coming back to you. Okay, so when I worked at the health department or in the school-based health centers, we had the same students coming to see me all the time. I was educating them. We had the same patients that were coming to see me all the time, and we formed a relationship. We formed that bond. We formed a trusting relationship, which was a huge positive. Okay, that individual was more apt to come get, you know, screenings and mammograms and you know, those kind of things that we're able to offer at the health department as well, that they might not have sought if they were if they hadn't, you know, formed that relationship. Whereas with health treatment, it's often very difficult to form relationships with your patients because they are sick individuals. So often they don't feel like communicating or forming that relationship. And then also because of the in and out. I mean, they come into the hospital, they're treated, and they go home, and hopefully they're not back, you know, to see you. So that is kind of a comparison of health promotion, which is what you see in the community aspect, whereas, you know, versus health treatment that you're talking about pretty much in any other form of nursing. I kind of like to switch gears here for a second and kind of share my research experience with you. So I went back for my DNP and earned that from Chamberlain University in 2018. I knew immediately when I went to school that I wanted my project to somehow focus on health promotion, community nursing, and even to take that a step further, how I could do that from my hometown, okay, rural Ohio, where the individuals truly have a lack of compared to individuals that live in the city, that they have transportation opportunities. In Adams County, we don't have bus services. We don't have taxis. You know, we don't have the rail car that goes down the middle of Cincinnati. We don't have those opportunities. We don't have urgent care centers on every block like you see in the cities. So I wanted to be able to share my expertise back in my hometown. So what I did, the one urgent care center that we have in West Union, I went to the facility and did some research to find out what their problem areas were and how I might be able to help. So the nurse manager there told me that patient satisfaction at that urgent care center was low based upon pre-surveys that they had already sent out and how they had gathered their data. The number one cause for the patient satisfaction was long wait times. Okay. Again, it was the only urgent care center in our hometown. And so long wait times were explanatory and really nothing we could do about that. But I will explain to you how my project did assist in that for that specific dissatisfaction. Other reasons why patients were dissatisfied, though, included the lack of providers, the lack of service options, lack of communication regarding their bills, disruptive waiting rooms, and then unfriendly staff. But because the long wait times was so prominent, and that was the major factor according to patients, that's where I focused my project. So what I did is I went to the research and found that there was a communication protocol called AIDIT. So what that stands for, that acronym, A is acknowledge, I is introduce, D is duration, E is explanation, and the T is thank you. So evidence has shown that when individuals come to a facility, if they're going to have to wait, and in this particular facility, they're going to have to wait, then if you follow this communication protocol, at least it will alleviate their concerns and make them feel like they're more than just a number. So when the patient comes in, research suggests that you introduce and acknowledge the patient. Hello, welcome Jane Doe, welcome to our urgent care. This is the introduce part. I am Amber Irwin. I am a nursing student and I will be taking care of you today. Now, duration. So right now there are 4 patients ahead of you. We have a board up on right beside the door that has listed how many people are ahead of you and what kind of wait time you're looking at. An explanation. So if for some reason, because it happens all the time, that those figures change, the amount of time that they're going to have to wait changes, the amount of patients that are ahead of them, or you get an emergency and the physician or nurse practitioner has to tend to that, explain to them, I'm sorry, Jane Doe, but this is what has happened and it's going to be an extra few minutes. And then at the conclusion of their visit, thank you, Jane Doe, for coming to our facility. It's been a pleasure treating you. We look forward to seeing you again. And research suggests that if you simply communicate and use that communication protocol, the satisfaction rates do increase. So luckily, that is exactly what happened with my project. We did a post survey after this project and satisfaction rates increased by 12%. I was absolutely thrilled with that. Anything that I could do for my hometown to see a smile on their faces meant a lot to me. And I would like to say that after I completed my project and I did finish and I graduated, I found out that the facility did continue using the AIDIT communication protocol. And that puts a bigger smile on my face to know that I've made a difference. And then advice for young people interested in community health. So the best advice that I can offer you is that it's really important to identify the area you want to work. So community nursing encompasses a lot, okay? You're talking about home health, you're talking about school nursing, you're talking about boards of health, you're talking about clinics and facilities like the Wiccan Family Planning that I worked at. Lots of facilities that offer community service and health promotion activities. So finding that specific area that you're interested in and the drive that you have will help, so you can focus your specific concentration and what you're interested in. And then understand that you will likely be working with patients with health disparities and providing treatment for the poor, the culturally diverse, and uninsured population it's part of it, okay? Oftentimes, whenever you're offering a community service, it's because those individuals need that extra help, okay? They have those disparities, and so they need help from their community. So understanding that that's a part of it, and being able to face your own biases, okay? That's especially important. And then knowing that there are numerous rewards. Patients are very appreciative, especially in my area, since they often come from a disadvantaged background. So anytime that they are able to utilize a service that they didn't think was going to be possible for them is really life-changing. And it's just wonderful to know that they really appreciate what you can offer them. And then you are often you're often offering health promotion activities. And so make sure that that's where your focus is geared, okay? Make sure that you understand that you're going to be working with individuals to, again, that primary prevention area. So things that you can do to avoid them getting sick, okay? So if you can find an individual that is possibly at risk for obesity and you help to educate them on proper food choices, proper exercise regimens, and you find out that you make a difference in that person's life, because again, you're forming those relationships, they're coming back to see you, and you notice an improvement in their health, that is because of you, partially because of you anyhow. And so again, just the multiple rewards that you will receive by going into community nursing. That is, it just really speaks for itself. And that is my experience in the community area. And it looks like I have about, boy, I ran it right close to time. I got about 3 minutes left. Is there anybody that has any questions about my experience? You can ask about my personal life. I have no shame. I'm always willing to answer those questions. Any questions about my experience, anything at all, I'd be happy to answer. Who's ever in control? I don't see the chat room. Is there any questions in there either?
Yeah, Dr. Urban, one of our in-person attendees will be asking a question. Yeah.
Okay.
So I think my question's about, is it ever frustrating to work in areas that are typically like underserved, underfunded? And like, what do
Yes.
you do? Like, I feel like yes is gonna be the answer, but what do you do to like combat those feelings of like feeling stuck, like between like a rock and a hard place? You know, like what do you do then?
Yes, I have been there too many times, actually, to be honest. And the best thing, it's you have to approach it by a multifactorial way. So number one, empathy for your patient. Remember, you are talking about individuals that is very frustrated themselves. Okay. We are getting frustrated, yes, as the healthcare provider, but think about the frustration that they're going through. So number one, making sure that we display that empathy to that patient. Number two, knowing our resources. That's something actually I should have put in these slides, and shame on me for not putting that in there. Being educated on what resources are available in your area. So if you get caught between that rock and a hard place, but you know the resources that are available that you can offer to your clients, that's worth $1 million right there. If, somebody comes to me and says, hey, I just don't have enough food to feed my family this week. Well, I know that the United Methodist Church offers a food pantry every 2 weeks. Now, it's an advantage because I live here and I know those things. If you're not from the area that you choose to service, then get your own education. Go to the health departments, find out the resources that are available to share with your clients. And then at worst case scenario, and you just come up against a roadblock, let that patient know this isn't the end. This is not a failure. I'm going to do research. At your next visit, hopefully I have something that I can offer you. Okay, so offering that hope and just doing some research and finding something, because 9.5 times out of 10, there's something out there for those individuals. You just have to go on the hunt for it.
Oh, thank you. And then my other question has to do with the pandemic. I think a lot of rural communities face different situations where there's perceived maybe more like distrust in science, and vaccination rates are lower in rural communities. And what does that look like for you?
Yes, you are so right. And don't get me on my soapbox here, honey, because that's just about where you're ready to take me. Yes, I come from a very rural area, and there is a lot of individuals in this area that have expressed their concern, and the lack of trust in science, the lack of trust in healthcare providers, and the fact that they truly have expressed that they do not believe there was enough research that went into the vaccination process and the studies. And so we do have a much lower rate. As a matter of fact, we were still in the red in Adams County, even when Cincinnati had kind of backed down. And that's sad shame. I mean, we have 3,000 people in West Union to vaccinate. I have no idea how many people there is in Cincinnati, but I can imagine that's only times 10. So it's very frustrating. And what you really have to do is check yourself, because if you were to argue with those individuals, which believe me, a time or two, it's crossed my mind. It has. But what good does that do? Absolutely nothing. So education, I have found, I have this in my own family. I'm vaccinated and many people in my family are not. I have found the best way to approach it is not to argue with them, but to sit down with them in increments and educate them. So now, even though it's taken me 7 or 8 tries, my close family member recently told me that he's getting ready to go get his vaccine. You know,
It's impressive.
yeah, yes, you know, it took some time, months actually, and many phone calls, but maintaining your cool, maintaining patience, understanding where they're coming from. Okay, no judgment. Okay,
Mhm.
you know how you feel about it. I know how I feel about it, but to judge somebody based upon that, we know in the healthcare field, we're always going to have somebody with differing opinions, different outlooks, and we have to respect that. Okay, that's what makes us who we are in the United States. And so just working on it a little bit at a time. You know, better late than never, right? I know that vaccines were offered, what, 8, 9 months ago when I got my first one, but at least he's getting it now. Maybe that'll still make a difference. I hope that answers your question.
It does, thank you. I admire your continued commitment to serving rural Ohio.
Trust me, it wasn't always easy, and I didn't always have a smile on my face. But I made it happen, and it turned out positive in that situation. I've still got a few family members to go. Let me look at the chat board too. It looks like it has, since you serve in a rural community, have there been things that you advise someone to do and they can't afford it or don't have time to, like a healthy diet with fruits and vegetables, and they cannot afford it? Absolutely. I have had that happen several times, and it's very unfortunate. And that's why it's so important to know about those resources, like those food pantries that I have. There is several situations where we have local produce stores that will have fruits and vegetables left over that are still ripe, they're not rotten, and they'll hand that over to the food pantry. Now, oftentimes people have that shame factor. They don't want to go to the food pantry, but I know, again, knowing your resources, that I can call that food pantry and say, hey, can we meet with you one-on-one? So this doesn't have to be a situation where the person is seen driving up and getting the food. And so I know those kind of things that are available that I can help with. Now, I'm just going to be honest. I wish I could save everybody, but there are those situations where people just won't accept the help, or I try and I'm not successful, but I'm never going to stop trying. Every time that they come in, I'm going to give it a go every time. And every time that they come in, a few weeks later, maybe I'm successful that time. And if that works, then, you know, again, it's still health promotion. I got to them in time. Maybe not on my time, but on it still happened within a reasonable amount of time. Anything else? It has been an absolute pleasure. I know that I ran over by a few minutes. I'm sorry about that, but you can tell that my passion is here. I love community nursing, and I hope that maybe I said one thing today that might encourage one of you to help in your hometown or anywhere where there is individuals that need the help. And I thank you for your time.
Thank you, Dr. Irvin, for your presentation.
Thank you. Thank you.
All right, we'll be going into our breakout rooms for the last part of our discussions. So I will be changing that.